Giant cell tumor is a relatively uncommon tumor of bone that comprises of multinucleated osteoclast-like giant cells, and because of this it is also called osteoclastoma. What are these giant cells and from where they come? We will start it from a very basic level. So let's say this is a bone and this is a long bone, that is femur by the way. Histologically there are two types of bones. The hard, dense and rigid bone, it is called compact bone, or it is also called cortical bone. So this is the compact or cortical bone. The other type of bone is called spongy bone. It is much less dense and it is thrown into trabecular folds. It has much greater surface area as compared to the compact bone. And of course here is the medullary cavity. Long bone, it consists of three parts. The ends of long bone, these are the ends of long bone, they are called epiphyses. So these are epiphyses of long bone from here to here and from here to here. And then in between them, in between those ends, this part of bone, it is called diaphysis. And then there is a sort of neck-like structure here that is called metaphysis, and this metaphysis, it is present between epiphysis and diaphysis. Now you can understand from this diagram that diaphysis, it consists mainly of this which bone? Histologically it consists mainly of compact or cortical bone. You can see it consists of mainly that dense, hard and rigid compact or cortical bone. While compare this with the epiphysis and metaphysis, epiphysis and metaphysis, it mainly consists of spongy bone. It is also called, by the way, the spongy bone, it is also called cancellous bone. So it mainly consists of spongy or cancellous bone, and along with that there is a very thin layer of what is this bone? Compact or cortical bone. So this is the structure of epiphysis and metaphysis. Now if we zoom into this spongy or cancellous bone, you can see that it is thrown into these folds, and these folds are called trabeculi or trabecular folds, right? And if we zoom at this, you can see that here is that bony matrix. We will not discuss the detailed histology, but here is the bony matrix. It consists of osteoclasts, and then there are osteocytes. Let's not go into details, but this much knowledge of histology is crucial to understand the pathology of giant cell tumor. Although apparently the bones look like a static structure, but actually the bones are quite dynamic. They undergo the process of bone remodeling, whereby the old bone is continuously and gradually replaced by a new bone. So as we have discussed that the spongy or cancellous bone, it has been thrown into these trabecular folds, and because of this it has much greater surface area. And this exactly is the reason that this spongy bone, it undergoes remodeling 10 to 15 times greater as compared to the compact bone. So most of the remodeling, it occurs in the spongy bone, although compact bone also undergoes the process of remodeling, but it is much greater in the spongy bone. We need two types of cells for bone remodeling: the osteoblasts or bone forming cells, and these osteoclasts, these bone eating giant monsters. These are multinucleated giant cells and we call them osteoclasts. They are involved in the process of bone resorption. Where these cells come from? There are some cells called mesenchymal stem cells or mesenchymal stromal cells or bone marrow stromal cells. These cells come from bone marrow, and these cells, they through a multi-step process, first they form pre-osteoblasts. These are osteoblast precursors which ultimately form the osteoblast. Now from where these osteoclasts come from? Within the circulation, there are some cells called monocytes, and they circulate within our circulatory system. These monocytes, under the order of pre-osteo and osteoblasts, they can come out of circulation and they will form pre-osteoclast first and then ultimately osteoclast. Now the question is how these pre-osteo and osteoblasts give these orders to the monocytes. Well, they release some chemical messengers, and these chemical messengers they then order these monocytes to come out of circulation and form the osteoclast. One of this chemical messenger is rank L or rank ligand, right? And the other is MCSF, monocyte colony stimulating factors. So under the action of these chemical messengers, these monocytes, they will form first pre-osteoclasts, and then these pre-osteoclasts, they will fuse together and they will become more specialized, and ultimately they will form the osteoclast. And again, rank ligand, rank L as well as MCSF is required during this process. So the point to understand here is that these are actually pre-osteo as well as osteoblasts that causes formation, activation as well as proliferation of these osteoclasts. They cannot form by themselves. You know, these monocytes, they also form macrophages. In some tissues where only MCSF, monocyte colony stimulating factor, is released and not rank ligand, only this is released, it will then form macrophage. And when both of these are present, it will not form macrophage, but it will form pre-osteo as well as ultimately osteoclast, right? So rank ligand, it is necessary to form the osteoclast. Now that we have seen that from where these cells come from, now let's understand the process of bone remodeling in a very simple way. So let's say we have zoomed into this part of bone, and here we have osteoblasts. Now these osteoblasts, what they will do? They will call osteoclast first. And how they will call osteoclast? By releasing rank ligand as well as MCSF. So here come that monster osteoclast multinucleated giant cell, and it will start the resorption of this bone. It will dissolve this part of bone and it will form a sort of den here, right? And then they will stop calling this osteoclast, they will stop releasing rank ligand and MCSF, and this osteoclast will go back, and these osteoblasts will come here. They will now start, because they are osteoblasts, they are bone forming cells, they will start laying new bone here. Some of these osteoblasts, they will differentiate into osteocytes, while some will differentiate into bone lining cell, and some of them, they will undergo the process of apoptosis. So here the bone that was lost, that pit or den that was being formed by osteoclast, it has now been filled by osteoblast. So this is the normal process. Now let's see what goes wrong in the development of giant cell tumor. Now let's say that this is a osteoblast precursor cell, or you can call it pre-osteoblast. Now what happened with this osteoblast precursor cell is that it had underwent a series of mutations such that it is now a neoplastic cell. So it has underwent a neoplastic change, and because it has now become neoplastic, it will not differentiate into a mature osteoblast, but it will only care about dividing itself. So it will divide itself and it will form lots of neoplastic population of these stromal cells, these pre-osteoblastic cells. Now although they are less differentiated, but they are differentiated enough that they can release the rank ligand as well as MCSF. So because of this, they will call osteoblasts. And osteoblasts, these innocent osteoblasts, they will perform their normal job. These are hardworking people. They will cause bone resorption. And now these osteoblasts, they will expect that these osteoblasts, they will lay down a new bony matrix, but these are neoplastic cells. They won't do so. They won't form a new bone as that happens normally. What they will do rather is that they have got some space to divide, and they only care about dividing themselves. So they will divide and divide, and they will form lots of population of these neoplastic stromal cells, and they will call more and more osteoclasts, and more osteoclasts will come, they will dissolve more bone, and these cells will continue to divide and divide. They won't be performing their normal task, but they will only care to divide. They will uncontrollably grow. Of course, there will be some monocytes as well who haven't yet underwent the process of transformation into osteoclasts. So this is actually the histological picture of giant cell tumor. Fortunately, it is a slow growing tumor, so it is well circumscribed, just like any other benign tumor. So this tumor, as we have discussed in this schematic diagram, in this actual diagram, high magnification diagram, the similar picture you can see that we have multinucleated giant cell evenly placed within a sea of mononuclear cells. Some pathologists like to use such a artistic terms. They call it that multinucleated. These are these multinucleated. So they say that these multinucleated giant cells, they are evenly placed within a sea of mononuclear cells. Mononuclear means that they have single nuclei, and multinucleated that they have more than they have lots of nuclei, maybe more than 100 as well. And what are those mononuclear cells? They have single nuclei. And what are these? What are these cells? These cells. These are stromal cells. These are osteoblast precursor cells, and these are actually neoplastic cells. Here in this diagram, you can see the background of these mononuclear cells. These are neoplastic cells, while osteoclasts, they are not neoplastic. They are actually reactive cells. They are performing their normal job. These osteoclasts are the innocent cells that were performing their normal designated job. But unfortunately, while performing their duties, they have inadvertently contributed to the pathophysiology of this disease. Right? So this is the histopathology. And by the way, you will see that there is no calcified or uncalcified bony matrix, because these undifferentiated cells, they can only divide but they cannot lay the bony matrix. So there will be loss of bony matrix. This tumor usually starts from epiphysis, and it may involve the metaphysis. It may extend to metaphysis, and usually it starts from the trabecular part, I mean the spongy or cancellous bone. Why so? Because as we have discussed, the most likely reason is that this part undergo most remodeling. So chances of something going wrong is greatest in the spongy bone. So usually it starts in the spongy bone of epiphysis, and it may extend into metaphysis, as well as it may extend into the cortical or compact bone, and it will lead to the thinning out as well as expansion of this cortical bone. So arise from the trabecular part of epiphysis, and outward expansion causes thinning of outer cortical bone as well as cortical expansion. And it is red brown, soft and friable. On gross appearance, it has red brown appearance, and that this tumor is soft and friable. Why so? Usually the bone is hard, but it is soft. Why? Because there is no bony matrix, there is no calcified bone here. And because bone is dissolved during the formation of this tumor, it is a lytic lesion, and during this process some blood vessels may be ruptured, and because of this there may be some areas of hemorrhage as well. And that's why this tumor on gross appearance, it looks like red brown in color, right? I like to call this giant cell tumor as genu tumor. Why? Because in almost 50% of cases, in half of cases, it usually involves the lower end of femur or upper end of tibia. I mean, in 50% of cases, it involves the area near the knees, and that's why I am calling it genu tumor. It's just a mnemonic, nothing else. The usual age of presentation of this disease is from 20s to 40s. It is very rare in young children as well as adolescents. We are not sure of the exact reason for this, but there is a hypothesis for this presentation. Actually, in children and young adults, what happens that during the process of bone remodeling, the process of bone formation is greater as compared to bone resorption. I mean, the osteoblasts, they are predominantly present as compared to osteoclast because they are of growing age. So osteoblasts are more as compared to osteoclasts. So it means that in children, osteoclastic tropic factors are down regulated. The chemical messengers to call the osteoclast, they are less expressed in children. So that may be a reason that it rarely presents in the children. Compare this with osteoblastoma. You know, the mean age of presentation of osteoblastoma is 12 years. Clinically, this tumor, it may cause swelling as well as pain near the joint or at the site of tumor. Also, because the bone at this point is weakened because of absence of calcified matrix, it will become more prone to fractures. Little or no trauma may lead to fracture of involved bone. We call this pathological fracture. Although this is a benign tumor, but very rarely, in 2 to 4% of cases, it may metastasize to lungs. Well, how can a benign tumor metastasize? By definition, benign tumor is a tumor which cannot metastasize, but this tumor is an exception. It can metastasize, but even when it metastasizes, it does not lead to worse prognosis. In lungs, it maintains that benign histological picture and even it may usually regress. So that's why we use the term benign metastasis for such metastasis. Some authors even believe that this metastasis is not a biological phenomenon. It rather results from the surgical dislodgement of tumor fragments into the blood. So it is an iatrogenic phenomenon, not a biological phenomenon. Now let's see the radiographic picture. So here is a case of giant cell tumor from MedPic's website. And you know, generally the bone, they are dense, they are calcified, and because of this they appear whitish on the radiographs. I mean, they are radio opaque. But here at the site of this lesion, giant cell tumor, because there is no calcified bony matrix, it's a soft tissue, so it will appear as a radiolucent lesion. Like this, you can see this is appearing much more darker as compared to this white bone. So lytic lesion is seen on the radiograph. And here also you can see this empty appearing lytic lesion, nice, well demarcated. This is the giant cell tumor. Some pathologists also like to call it soap bubble appearance. The treatment is surgical resection, but there is a drug that may be used as an adjuvant therapy. Let me tell you what is that drug. Now, as you know, the pre-osteo as well as osteoblasts, they release rank ligand as well as MCSF to cause formation, proliferation as well as activation of osteoclast. There is a monoclonal antibody against this rank ligand. This monoclonal antibody, it will destroy this rank ligand, and because of this rank ligand will not bind with the rank receptor on monocytes as well as pre-osteoclast, and thus it will decrease the formation of osteoclast. It will decrease this process, and thus it will prevent excessive resorption of bone as occur in this disease. The name of this monoclonal antibody is denosumab. Mab means monoclonal antibody, usu means bone, and den is just the name of this. It doesn't mean anything as far I know. But how can you remember the name of this drug, denosumab? Well, it is very easy to remember the name of this drug. Consider this den or pit created into bone by the osteoclast. Now let's say a tank comes. So here comes the tank and it falls into this den. A large tank fall into the osseous or bony den. So this is actually the mnemonic. Just replace the tank with rank and place this large L here. So it means that this rank ligand antibody against this rank ligand is denusu, osseous denosumab. So denosumab is the antibody against rank L, against rank ligand, not tank, rank. And because this den was created by osteoclast, you can remember that it will prevent the formation and activation of osteoclast. Just remember that this denosumab is not against rank. Rank is the receptor. It is not against rank. It is against rank ligand. Right? Thank you so much for watching this video.